All right, so inflammatory derm path. Well, it's hard. Why is it hard? Well, we have bewildering terminology. Although there are some common recurring diagnoses that surgical pathologists encounter, and I think it's important to be aware of some of these. So here's my big 10 for you. Spongiotic dermatitis, psoriasis, lichen simplex chronicus, lichen planus, erythema multiforme, toxic epidermal necrolysis, graft versus host disease, drug eruptions, granuloma annulare, erythema nodosum, and calciphylaxis. So spongiotic dermatitis. So spongiotic dermatitis occurs in sort of three histologic phases that will go over the acute phase, in which you have a normal basket weave stratum corneum. You tend to get pallor of the keratinocytes, a variable amount of spongiosis, and you often, though not always, have spongiotic microvesicles within the epidermis, a variable papillary dermal edema, and a superficial perivascular infiltrate, predominantly composed of lymphocytes with or without eosinophils. Unfortunately, it's sort of rare to see spongiotic dermatitis biopsied in the acute phase. This is what a clinical case might look like. This is just a really bad case of poison ivy. You can see the linear blisters on the arm where the edge of the leaf brushed up against the patient. Microscopically, this is what it might look like. Again, you see a normal basket weave stratum corneum, spongiosis here. You see the increased space between the keratinocytes and the epidermis. And if that hydrostatic pressure from the accumulation of the edema fluid within the epidermis gets strong enough, it actually ruptures the desmosomal attachments, and you get these spongiotic microvesicles within the epidermis. And then over time, as the epidermis has a chance to react to this inflammatory process, you get into the subacute phase of spongiotic dermatitis. And with the subacute phase of spongiotic dermatitis, what happens is the epidermis tries to proliferate its way out of the problem. Okay, and because of that, you don't get appropriate terminal differentiation of the stratum corneum, so you have retained nuclei in the stratum corneum, so you have parakeratosis. And often with some serum in that parakeratotic scale, or it's a wet crust. You'll have a diminished granular layer because, again, the epidermis is not maturing normally. You still have spongiosis, and because the epidermis is trying to proliferate its way out of the problem, you have epidermal hyperplasia, or what we like to call in derm path, acanthosis. And then you get that same variable superficial perivascular infiltrate of lymphocytes, often, though not invariably, with eosinophils. And typically you see less edema in the papillary dermis. So here's a case of subacute spongiotic dermatitis. Okay, now you see, yes, there's sort of serum still in the stratum corneum, but you see parakeratosis, a diminished granular layer, still see some spongiosis in the epidermis, and then a variable perivascular infiltrate. And here's a different case with less pronounced